Let's get started. Thank you all for joining us this evening. I'm Barbara O'Brien, the director of the Oklahoma Perinatal Quality Collaborative, and I'll let Chad Smith introduce himself too.
And good evening, everyone. Thanks for joining us. My name is Chad Smith. I serve as the medical director for the Oklahoma Perinatal Quality Improvement Collaborative and serve as the chief medical officer at Mercy Hospital, Oklahoma City. Thanks for being with us this evening.
So Denise, if you'll go to the next slide, our agenda for this evening, we're going to, as we always do, provide some updates. We do have OSDH and Maternal Health Task Force updates, and then we're going to provide some updates. OHCA will talk about the postpartum extension and federal poverty level increase that went into effect on January 1st. We have an update on our Oklahoma Safely Advocating for Those Engaged in Recovery, update on that work, and then other business. So thanks for being here this evening. Joyce, I'll turn it over to you for updates that you have.
Okay, thank you, Barbara. We just have a few quick updates that we would like to give in relation to the activities that Barbara referenced. And I wanted, first of all, to let everyone know that we've got some new items coming up soon that you're going to be hearing more information about. So we're working on emergency obstetric simulation trainings to be available across the state. So you'll have more information in relation to that. Also an aspirin therapy campaign. We'll work closely with the Oklahoma Perinatal Quality Improvement Collaborative and the George Kaiser Family Foundation, March of Dimes, and many others in relation to that. Also, we have a Maternal Health Awareness Day. ACOG has begun a new Awareness Day for maternal health. They are having that on January 23rd. So you'll be seeing some postings. We'll be having interview with some of our physician champions, such as the chairs of our Maternal Mortality Review Committee, Dr. Chad Smith and Dr. Kate Arnold, and many more. But just look for those. It's a new opportunity for us to draw more attention to maternal health. And so we want to do that in the best way that we can and get that information out as needed. Also, there is working on racial disparities training in person. So that will be available along with the e-modules. So that is coming up this year. And a website for provider patient information. So those are all items that are coming soon. In that regard, also there is legislation that is coming through that's sponsored. ACOG is heading it up, and also the OSDH, as well as several other organizations, are sponsoring it to require a referral for an autopsy for all maternal deaths. So that is another item that we have in legislation that is very much needed, that is hopefully going to come forward and do well this year. Also wanted to reference that our maternal health annual report on maternal health morbidity and mortality is out and is available now. We're looking forward to, in the future, we may do a special session in relation to kind of go over some of the items in that report, but did want to let you know that it's out, it is available. Barbara's got a nice little link right there on the pages that'll go out that you can click on it and get directly to it. It has information, all the latest information in relation to maternal health, morbidity, and mortality. In it, you will see several things that aren't that surprising and other things that may be. Obesity and smoking rates, along with other chronic health issues, continue to impact maternal health in our state. We also still are seeing significant racial disparities in rates of severe maternal morbidity, maternal mortality, and pregnancy-related mortality. But I did want to state that the maternal mortality, we have seen some improvements in those areas and in maternal mortality. While there was some declines in earlier years, we have seen some improvement in the most recent period. So we are hoping that we can continue that. COVID did cause some issues, so we are going to see some issues from that, unfortunately, in 2021 data. But did want to know that hard work is going on to make those improvements in maternal health, all these items that we get together with in relation to quarterly, and we've been working together for the last years in many efforts, along with the Maternal Mortality Review Committee, Maternal Health Task Force, Perinatal Quality Improvement Collaborative, Preparing for a Lifetime, and so many other safer initiatives you're going to hear more about. Many initiatives that have been working hard to make that impact. We are seeing it come through. So I wanted to let everyone know about that. There's more details in there, but I know I don't have time. I've only got a brief period today to speak in that regard. So I will let you click on the link, and then hopefully in a future meeting, we can kind of go over some of those further.
Thanks, Joyce. And I do want to clarify the emergency simulation, OB emergency simulation training is for emergency departments. So just wanted to make sure that was clear. And Denise put the link to the maternal, to this report that's in the chat. So thanks, Joyce. And Chad does have, Dr. Smith has some information if you go to the next couple of slides, Denise. And Dr. Smith can do an update on that, a little more information on the legislative update.
Yes, so regarding legislative updates, Senate Bill 399, as you can see here, we're waiting for this to be introduced in this upcoming legislative session. And really this has to do with our Maternal Mortality Review Committee and really requiring hospitals or birthing centers to report maternal deaths to the Office of the Chief Medical Examiner. So at least we have start to get a little bit better record, but then also encourage more autopsies be performed on these scenarios so that we can gain more information as to exact cause of death, because oftentimes absent a specific reason to request or require that autopsy, they're oftentimes not done, and the default reason is based off of the medical documentation in the electronic medical record. Also wanted to kind of broaden the types of deaths to be investigated to include maternal deaths, authorize the Office of the Chief Medical Examiner to provide documents to the Maternal Mortality Review Committee so that we can utilize that within our process, so that again we can get as most accurate information as possible, to where then we can ultimately begin to learn a little bit more about how we can prevent preventable causes of maternal death. So more to come. We're waiting again for that to be fully introduced. We anticipate that there'll be waves of word changes associated with many of these bills, but this is one to kind of keep an eye out. And certainly if you have the ear of a state legislator, definitely put a bug in their ear that this is something that's important to you as a maternal health provider in the state of Oklahoma. Next slide.
Thanks,
Okay.
Dr.
Yeah,
Peters.
and I think sorry, I
Kevin.
wanted to go back to that and one final thought. In addition, the Maternal Mortality Review Committee is also working to use our different advocates within state legislature to, again, how do we expand the role of the Maternal Mortality Review Committee, in so much as we provide this nice year in review. We're trying to be creative and respectful for how we can really share more information in a way to enhance maternal health in the state of Oklahoma. So again, that's one of the things that we're looking to seek to do as part of the Maternal Mortality Review Committee, so that we can continue to improve and advance the level of thinking that we have from that group. So that's it, Barbara. You can go to the next slide. Sorry.
Okay. Thank you.
Barbara?
Yeah, go ahead, Joyce.
Just briefly before we do that, I just wanted to state that in that report that we were just announcing, the Maternal Mortality Review Committee recommendations are in there that were currently made this last year based upon those reviews that were done and what was most needed to make a difference in our state moving forward.
Great, thank you. Yes, so please access that and review. And as Joyce said, we will likely have another session, one of these meetings, or even a separate meeting to go into more detail on the information that's in this report that just recently came out. So thank you both. Next slide. Stephanie Pierce is going to provide us with an important prescribing update that's hot off the press just from Thursday. So I'll let you, Dr. Pierce, come off mute and provide the update. If you'll go to the next slide, Denise.
Okay, thank you. I wanted to just mention this. This is regarding the buprenorphine prescribing regulations. So with this recent signing at the end of 2022 of the Consolidated Appropriations Act of 2023, there was a removal of the waiver program that's been required. So what's called the X waiver that has been required to prescribe buprenorphine. Congress has now removed that that requirement at the national level. So importantly, people that are registered with the DEA should have or should be receiving this communication from the DEA. If you had the waiver and had like an X number in front of your DEA, I know I and at least a few of my partners have already gotten an email from the DEA that has your DEA number, a new card that has the X removed from it. So basically, my understanding, and I'm still getting more information about this, is that any prescriber who is registered with the DEA can now prescribe buprenorphine, that there's that specific X waiver is no longer required. So this is like any controlled substance that we prescribe at this point. There used to formerly be a cap of 30 patients that you could prescribe buprenorphine for per year, unless you applied for the capacity to prescribe for more than 30 patients. That cap has now been removed. And there's also going to be new training requirements for people who are registered with the DEA. And it's still in discussion about what that means for people who already have a DEA registration, whether we're going to need to complete that additional training. I don't think we know the answer to that yet, but the goal of this is to remove barriers to buprenorphine prescribing, to allow more providers to prescribe it, and then hopefully to kind of remove again some of the kind of perception that buprenorphine is this, super complicated medication to prescribe. Obviously, you need to know about the medication you're prescribing and make sure that you're aware of any pertinent, regulations associated with it. But this is meant to kind of remove a lot of those barriers, both for patients to access and for providers to prescribe.
Any questions or comments from anything we've talked about so far?
I see Teresa's on here. Teresa, have you heard, what's your take on this? Have you heard anything about it?
Nothing additional than what you shared. It's not necessarily a concern, but we had, for OTPs, for opioid treatment providers for methadone, we have a specialty type. And so we're able to track who's providing methadone specific to MOUD for opioid use disorder. And so that would be the only thing it might complicate it a little bit about, is this person being prescribed opioids for opioid use disorder, just to be able to track outcomes and things like that. Also, there's no requirement, never has there been a requirement for there to be a referral to be assessed for therapeutic services, because obviously the best outcomes are medication along with therapy. And so that's the only thing. I just don't want the pendulum to swing the other direction where, okay, now we're all prescribing buprenorphine or these drugs for opioid use disorder. Because we already have a little bit of that right now, where we have these pop-up doctor shops. People pay cash, they get the medication, even if it's for opioid use disorder. And so that's the only kind of thoughts I have on that, is like, how will we be able to really track and follow that? And also, how do we help prevent the pendulum swing that we had with pain management? So that's the only thing I have.
Yeah. And you mean, Teresa, like in terms of someone just prescribing the medications, but not being incentivized to like actually get people connected with mental health services as well?
Yeah.
No, I agree.
No, we
I
won't
don't
go.
have a solution, but
I know. And I don't think we know, like, is this going to result in fewer people getting, referred to mental health services, or just more people getting the medication that wouldn't have otherwise, so yeah.
well, I mean, safety first. Obviously, we want people to get the medication as quickly as possible to reduce potential for overdose.
Mhm.
Yeah, it would be great to have that linkage. And so
Yeah, we'll be monitoring the situation. As I said, this just came out last week. We just were made aware of it. So more to come as we learn more, but thank you, Dr. Pierce, for providing the update. And Denise, if you'll go to the next slide, I was going to provide a few updates from OPQIC. First of all, could go to the next slide. We have a new staff member, Katie Morgan, joined our team as a nurse program manager on December 6th. Katie, there she just came off camera, or she did, now she didn't. So wave, say hi. A lot of y'all have already met Katie, and we're really excited to have her on our team. So we welcome and thankful that you joined our team, Katie. And then also I learned just like seconds ago, literally, Barbara Koop has now been approved. Everything's in place where she is going to start doing some consultation for us. So Barbara Koop is going to be able to be doing a few things with us as well as we move forward. So we're excited about that. It will help us with capacity issues. So thanks so much. Barbara, we look forward to having you back. And a couple of updates on Team Birth. As you understand, it is a cooperative agreement. We are between the State Department of Health and the Health Resources and Services Administration. We are partnering with Ariadne to bring Team Birth to Oklahoma birthing hospitals. We're the first state to do so statewide. So you can see with our next slide, we have already these hospitals that are implementing Team Birth. And just a reminder of all the hospitals that are involved, and our cohort 3 hospitals began work on this in October. So here are our cohort 3 hospitals. So that means we now have 27 total Team Birth hospitals in Oklahoma out of 44. This affects approximately 34,000 of our annual births, which is about 71%. So that's pretty awesome. We're excited about that. And we are recruiting for cohort 4, which will start planning and preparation in late spring of this year with an anticipated launch in October of next year. I mean, of this year. I'm getting my years mixed up. So yes, in 2023. So if you're interested, I know I've been in contact with some of you for cohort 4. Please let me know, and we will be beginning the work on that this spring. So we're excited. Wanted to show you a little bit of preliminary data about teen birth. This slide, these that I'm showing you are unpublished data. They're not for distribution. They are working on getting these published, or will be at some point, but this slide here shows one of the ways we measure teen birth is with clinician surveys that happen before you implement, and then 6 months in, and then post implementation after about a year. And looking at these data, you can see this is Massachusetts hospitals compared to Oklahoma hospitals. And prior to implementation, you had a smaller percentage of those who strongly agreed that the doctors and nurses in this hospital worked together as a well-coordinated team. But you can see for both states, there is an improvement, and particularly in Oklahoma, which doubled the hospitals that answered that they strongly agree, or the clinicians, I should say, with that question, and it totally removed the strongly disagree and slightly disagree. Looking at the next question, another one from this survey, the clinician survey, nurse input is well received in this clinical area. This is comparing Massachusetts and Oklahoma physicians. And you can see that both states have a large increase, and even more so in Oklahoma. And again, we've removed those who answered strongly disagree and slightly disagree. So we always talk about how this team birth is a structured communication model that implements shared decision making, and how patients are those who are very empowered, but it also, we find that nurses and physicians also have benefits, and it improves the unit culture and the communication. So wanted to show you all those 2 slides. Looking at our next slide, this is some patient survey data from cohort 1 hospitals for OPQIC. And if you'll look for all of these, on the blue bar is patients who did not have a huddle, and the green bar is patients who experienced a huddle. You can see the numbers are lower for no huddle, because hopefully pretty much everybody's having huddles occurring with teen birth. So we expect that, but we will have more numbers as we are now adding our cohort 2 sites, and then we will be adding cohort 3 and 4. But you can see the marked improvement in all of these. This is the mother's autonomy and decision-making score. And all of these questions to those who answered affirmatively that their clinical team agrees with this statement. So all of these are very promising. We are now getting enough data too that we can break these down by race and ethnicity. So that is very important to look at as well. And we'll be sharing those as we get more data. But again, just looking at the autonomy scores that increase with the implementation of teen birth. And another slide, looking at our next slide, we have, this is a different score of trust scores by labor huddle. Again, the blue bar is no huddle, and the orange bar is yes. So you can see how these questions that are designed to measure the trust that a patient has in their clinical care team, which we know was impacted particularly by COVID, where people maybe don't trust healthcare providers as much as they used to. And you can see again, some of these are by 20 percentage points that they have an increase in their affirmative answers for all the time for these questions. So we're getting more data. I think there's one more, Denise, is that correct? Yes, so here's the next one. So we can see these also, everything that we have, everything that we measure has a positive response and a positive increase. So we're really excited about these data, and we'll be getting more as we continue to get more hospitals submitting survey data. So we're really excited about these numbers. Any questions or comments about these and about teen birth? I see some people on that are doing it and are going to implement. So thanks for joining us, and feel free to come off mute if you all want to share anything, but we're really excited. Okay, I think that is it from me. So Trailer, sorry. I'm going to turn it over to you for updates from the Oklahoma Healthcare Authority.
Hey, good evening. So it's been a busy month. So effective January 1st, we implemented the increased income limits for pregnant women from 138% of the federal poverty limit to 205%. So that's about, I want to say 38,000 annually for a household of two, which is mom and her baby. At the same time, we've also gone ahead and implemented the extended postpartum period from 60 days to 12 months. So that's currently in effect now. You haven't seen anything from CMS on it yet because we're still pending CMS approval, but we've had good conversations with them. We're confident we'll get that approval in this quarter. And the way they do those is we can always backdate the effective date back to the beginning of the quarter that we submitted it. And we submitted that state plan at the end of December. Right now we're looking at how we can put edits in the system to make sure that women don't lose coverage during that 12-month of continuous postpartum coverage. As you all know, we've been under continuous eligibility since March of 2020 due to the pandemic and the requirements to get the enhanced FMAP. So we are going to begin the unwinding and unenrolling process on April 1st. Now that Congress has officially uncoupled the continuous coverage requirement from the public health emergency and given us states permission to unwind in April. So what we're going to do there is we're going to look at all the women who had pregnancies that would have qualified for that 12-month, do a 12-month look back period, and then update their end date in the system such that if they were targeted for unenrollment during the PHE unwinding, we would not disenroll them from the program until their actual new postpartum end date, 12 months post the pregnancy. So we are working on getting some information out to providers, some flyers for offices. For example, we have sent out provider letters and member letters. We're putting updates in our member and provider newsletters so that everyone's aware of the change. We expect that this would impact around 2,500 women annually in terms of the additional coverage and raising the income threshold. A lot of those are coming from our more limited soon-to-be-sooners option, the citizen option. We will still maintain that soon-to-be-sooners option for those non-citizens in Oklahoma. I'm trying to think. I'll pause there for questions. Any questions about logistics? I will say that the benefit is going to be the same as all Title 19 senior care benefits. So access to behavioral health, depression screenings, treatment for anything found during those screenings. I know that we have a lot of current limits right now and rules in the system regarding like lactation services and social worker services. We're looking at taking those and annualizing them to see what that would look like if we were to add 12 months of coverage, because we understand that they may hit those limits early on in the postpartum period, and we don't want that to happen. But even before we do that, if a member hits a limit, we always have the ability to override that limit through medical necessity criteria and review with our physicians internally. So we're happy to work through that, but we are evaluating all those limits, seeing what needs to be raised as we move forward.
Trailer, it's
Yes.
Stephanie Pierce with OU. I just have a question kind of in general. So as an OB provider, do we need to be talking with our patients about, making sure that they're enrolled in the correct, thing? Like, what do I need to say to my patients to make sure that they're able to take advantage of this?
So what I would say is, if a member comes in through Sooner Care through expansion, their income limit is going to be 138% or below. If that if that mom becomes pregnant while on expansion and has not updated her eligibility file, we don't know she's pregnant. So let's say that, after the pregnancy ends and she gives birth or otherwise, her income goes up. She may be targeted for unenrollment because she no longer meets eligibility criteria for expansion because we just don't know that she was pregnant. So I would encourage as a physician just to make sure that their eligibility file is updated to indicate that their circumstances have changed and that they're pregnant. And that will actually raise the income threshold above that, which we would require for expansion, and give her that 12 months of continuous eligibility after the pregnancy ends.
And is that something that, and this is just a question that I don't know the answer to, is that something where if I told someone, make sure your eligibility criteria are updated, would they know what I was talking about? Or is there somewhere that I should direct them?
Sure, mysoonercare.org. So yeah, they should be familiar with their mysooner.org account. They go up there and they can update their income information, the contact information, and there should be a prompt that asks if there's their circumstances have changed, and pregnancy is one of those. I see a chat asking about this.
A couple of questions in the chat trailer.
Yeah, see one is asking a little more about CMS approval. What does that look like for someone who would be eligible under the new limits? The CMS approval is, so it's our state plan amendment. We submit, and our director of health policies on here, we submit a state plan amendment. Essentially, that's checking a box saying that we're raising the income limits for pregnant women and taking advantage of the 12-month postpartum period. And it's, we go back and forth, negotiate a little bit. This one's fairly straightforward. So it's pretty quick. They have 90 days after we submit to have a formal approval of that.
So that should take place by.
We expect to get approval by the end of March for sure.
Okay. But that doesn't mean that. Can they still, if somebody's eligible right now, like they had a baby in December, well, let's say they would have been cut off, because they were 60 days postpartum, but now they're eligible. That doesn't require waiting till the CMS approval takes place.
That's correct. We're already acting as if it's approved because we know, like I said, we're confident it'll be approval backdated to January. So we're acting as if it's steady state operations at this point.
Excellent. Thank you for clarifying my maybe poorly worded question, Barbara. I appreciate it.
I know we've had to kind of flow chart this out and look at all the various situations that we can encounter. And it's further helped, but complicated a little bit by the current continuous eligibility. So like I said, we've not been able to unenroll anyone anyways. Makes it a little easier for us.
Yeah, and just to clarify, I don't know if everyone's familiar with the requirement that you cannot unenroll. Can you provide a little bit of information on that, just so everybody in the meeting understands what you mean by that?
You bet. So when the public health emergency for coronavirus was initially implemented in March of 2020, states had the opportunity to receive a lot of enhanced federal funding that matches, it takes our current federal matching percentage up 6.2 percentage points, which has meant a lot of money for the state Medicaid program. But as the string attached to that was Medicaid agencies cannot unenroll anyone from the program for any reason unless they choose to unenroll, they pass away, or they leave the state. Those are the only 3 reasons we can unenroll. So currently we're carrying around 280,000 members on the program that technically don't meet Medicaid eligibility requirements. So think about folks that early on in the pandemic lost their jobs, they came on to Sooner Care because they needed it, have since found employment, don't need it anymore, and probably have third-party insurance through a commercial carrier or a small business employer coverage, and don't even access Sooner Care, but we cannot unenroll them. Just in December, right before Christmas, Congress came out with a new spending bill for the next year, one of which went ahead and decoupled the continuous coverage requirement from the public health emergency. So as we've been extending the public health emergency every quarter, that has meant that the continuous eligibility continues as well, but that's no longer the case. So what you may see is in April, it could be that the PHE is extended yet again for other reasons, but it's no longer tied to us carrying those eligible members. So we'll start the unwinding process in April. We plan for that to take 9 months. We have created a pathway that's very intentional and compassionate with our members and looking at them based on their current needs and utilization. So look for that first month in April to really targeting those members who came on the program and never utilized services. So like those ones that needed us for that month and then obtained employment or coverage somewhere else and just never used Sooner Care. So they'll be targeted for initial disenrollment, along with those folks that don't have kids under the age of a certain, under 6, or they then followed by those that have third-party liability. They have commercial insurance, for example, and Medicaid as a backup. Once you get towards that October to December period, we're looking at the last folks to unenroll will be those with chronic conditions, high utilizers, folks in the middle of a episode of care, for example. If let's say they're getting cancer treatment, those will be the very last individuals we target for unenrollment at the end of December. Want to give an update too on a request. There's so many players that kind of cross various work groups, but a request from one of our work groups that Barbara and Joyce have been involved in is the coverage of low dose aspirin for members at risk of preeclampsia. That is moving forward. We expect that to go into place in February. Not a lot of hoops to jump through on our side to make that happen, just a couple of system changes. So we are working on getting provider letters out to our OB providers and our high-risk pregnancy providers, as well as our pharmacy providers, so that everyone understands the process for prescribing that. It would be something that you would obtain through pharmacy, through their point of sale system, and as a non-prescription drug, much like we do prenatal vitamins. And so we understand the importance of that, very low cost impact to us, but high return on investment and value to our members. So we were happy to push that one forward. Letting you know too, on the horizon, we are moving forward with doula services for our members, our pregnant and postpartum members. We expect that to make it through the process such that we can implement sometime summer, probably looking at July or August to have that going.
That's great news. And I see a couple more questions, one from Teresa and another from Jennifer Buck in the chat.
Yeah, Teresa, the problem there is that woman can be eligible, but we just can't pay for services behind the wall. CMS slowly will start coming out with guidance around when we can pay for stuff behind the wall. There's light on the horizon for juveniles in the juvenile justice system that looks like in 24 and 25 CMS is creating opportunities to pay for their services. Hopefully pregnant women will soon follow them, but right now they can become eligible. We just can't pay for services behind the wall. Let's see, there's one. Jennifer, for the extension, is this just for newly enrolled women, pregnant person, or does a woman pregnant person who is still within the 60 days postpartum get the extension as well? Great question. So yeah, let's say a woman was not eligible today and the pregnancy ends and the 60-day ends. She can technically apply for Sooner Care and state, give all the information around pregnancy, pregnancy end date, and then yes, that woman will be eligible for the remainder of that postpartum period. So we would give the months, 10 months, let's say her 60 days right now, we'd give her 10 months of eligibility.
And how would do they need to do anything?
Yeah, so they would technically be new to the program. So let's say it's she makes 150% of the federal poverty level. She was pregnant through a private carrier, for example, lost coverage, is in her 90th day of postpartum. She would go through myseniorcare.org, put in her income information, say that she's applying for pregnancy related benefits, give the pregnancy end date, and we would calculate her eligibility period to fill out the remainder of that 12-month period. So yes, they would need, in my example, it's not a reapplication. That's assuming it's an initial application. If someone has come on and gone through the 60 days, that's going to be in the cohort of folks that did not lose eligibility because we have continuous eligibility now through the PHE. And we will look at their pregnancy end date and their files to make sure we don't unenroll them during the unwinding process until their 12th month, if that makes sense.
Yeah, okay.
But as with all things, there's never a perfect system rollout. As anyone that's worked with large scale projects like this. So please, advocates, let us know, reach out to us, let our member services know if you hear of this happening. It was an oversight, and we'll do our best to get it corrected on the individual member level.
Yeah, that's exactly what I was going to ask Asma. I know, Trailer, you've been working on a written document. I think that would be really helpful with the kinds of situations you've talked about, and that we have it in writing from you all, and also places where, I think like the health department, county health departments and the DHS offices can help with Medicaid questions. So where can they send people if they have questions? It would be helpful. I know you started working on one, but
so we have a large color flyer that is about to be available, that we'll make available on our communications website, that providers can print off and put in their own offices. We're also sending out provider member letters that will have a link to an agency website that you can visit that gives all that information, all the coverage information, as well as benefits and services and limits and all that stuff. And there'll be a Q&A, I believe, as well on that.
Okay, great. Thanks, Trailer. And if you need our help, we'd love for you. I know that I've asked, so send it to us too, and we can help distribute it and put it on our website and help in whatever way we can. So thank you so much, Trailer. Always glad to have you here to update us. We appreciate the changes and are really hopeful to see positive impacts from these Medicaid policy changes. So we appreciate your work on this and your partnership. Thank you. Have a good evening. Okay, up next on the agenda, Teresa Stevenson. Teresa, are you doing this or is Terry?
I think I am.
Okay. I saw Terry join too, so I didn't know who was going to be presenting. So
she can definitely fill in the blanks if I miss something. So
okay, well, I am turning it over to Teresa Stevenson, and you'll have to tell them your official title, Teresa, because it's really long.
Oh, Senior Director of Adult and Family Centered Substance Abuse Treatment and Recovery Services, as well as the State Opioid Treatment Authority. It just means I oversee all the methadone clinics in the state. Okay.
It was long. So thanks, Teresa. And Denise is sharing the slides.
Okay, great. So we're just going to give an update on our Safely Advocating for Families Engaged in Recovery. And it's a lot larger. We're going to focus currently on the family care plans and our regional partnership grants that are our RPG 6, which is focused on the STARS clinic, and then the expansion of that is the regional partnership 7, which will actually expand to rural communities and have an emphasis on tribal and Native Americans. And then we'll talk about the 2023 priorities and next steps for the work we're doing. Next slide, please. Again, these are the current grants that we have going on. The STAR Clinic grant is adding the S on the end which is additional services along with what is already occurring with the STAR clinic itself. And that will last through 2024. And then we just received their RPG 7, which is called the Compass Collaborative Oklahoma Maternal Pathway to Access Substance Use Treatment Supports. We love acronyms and being cute, I guess. So 2022 to 2027, which we have a cross-site, multi-site evaluation. It's a really intense evaluation they do on these programs, and it's evaluated in state with Dr. Bard with OU, as well as we have an outside evaluator that the grant requires called Mathematica. Yeah. And so the purpose and design of STAR Clinic, I think you all know that pretty well. We added some of the enhanced services, modified attachment, biobehavioral catch-up, which means that there are some services provided prior to delivery and then after. And then the outpatient other step down substance use treatment services available. There is housing and support assistance, as well as outreach to individuals in the community to help ensure they are aware of these services being available. We've had some really cool stories about some of our outside providers actually doing persons without homes outreach and identifying those individuals in the community, getting them into treatment, into housing, getting them referred to the STAR Clinic. That has allowed them to be able to have their child with appropriate care and be able to have the child go home with them after birth. So that's really cool. Next slide, please. Some of the STAR outcomes, and Dr. Pierce, if you have any additional or new information you want to share, please do. But the number of those served as of June 2022 is 150. Number of infants, 153. Number currently, well, then 16, but 85% of the families have been on an MAT. And percentage of infants placed in out-of-home care is 15% as of that time and date, which is really actually very low. And as we'll go to the next slide, because I'm always curious about that 15%. And if you look at this, this for over time, this is from Dr. Bard's preliminary studies and information or outcomes. And if you'll look at that, there's a very large percent of those moms and babies that have been able to stay together even beyond the birth itself. So those that went home stayed home. There were only 4 that were removed, but actually one of those was reunified. And I have the question, I said, removed 24 that were removed. And I said, who are those people? What was the reason for removal? And those actually, every single one was due to methamphetamine, which we know is one of the drugs that child welfare really looks at as a direct removal. So I'm like, what do we need to do to address that? How can we impact that as we move forward, such as bed-to-bed transfer? What other services and supports can we put in place to really reduce that from happening? Okay. Next slide, please. Oh yeah, we're doing the family intervention response to stop trauma, which is the first clinic in Everett, Washington. It is a model where there's a legal medical partnership. So we are working with legal aid to get a contract to provide legal support services at the hospital itself while the person's there, to be able to assist and hopefully reduce the potential of removal and future involvement. And some of the outcomes that have happened with the first model, previously is 15% are known to have had a court case, 89% did not result in removal, which is really cool. And we're super excited to look at that. They currently work with child welfare cases or not criminal. So we would like to explore that because we do know that there are women that are being incarcerated for neglect due to having a substance use issue prior to delivery. And so that's a concern that we have as well. So we'll be looking at also expanding this once we get this model kind of implemented here in Oklahoma County first. And I believe Tulsa County and Oklahoma County. Okay, next, please. Yeah, we'll be doing the medical partnership with STAR Clinic. Proposal for legal aid staff will be co-located at OU. Legal aid staff can assist with the multiple issues. So this funding actually came from a supplemental with the RPG6 that allowed it for us to do that, but we do plan to continue that on beyond just the supplemental funding with other state opioid response funding. Next slide, please. So the COMPASS goals, which is what we just received, will increase well-being, improve permanency outcomes, and enhance the safety of children who are in and at risk of out-of-home placement as a result of parents, caregivers, opioid or other substance misuse, and which is very similar to what we are doing with the STAR Clinic. However, this will be broader population rural communities. Builds hope and resilience for pre and postnatal persons, infants, child, and families exposed to substance in rural, tribal, and other populations disproportionately overrepresented in child welfare, and reduce the likelihood of intensive child welfare intervention or legal involvement. Next slide, please. So these are the strategies that we'll be using as a part of this. We will be doing the prenatal family care plan to really help expand that. That'll probably be our second rollout of our pilot project that we already have happening in Tulsa County right now. Wonderful. I'm so excited, Barbara. You were talking about the teen birth and that's getting such great attention and outcomes, because that is also one of the things. How can we incorporate what we're doing with our family care plans into what's happening at the teen birth, and can that be a part of that? It's very informational for child welfare, the legal system. Really working on tribal engagement. We actually are a part of a policy academy that has invited several tribal nations and the Southern Plains Tribal Board to be a part of that policy academy to really help develop and help us better understand how to communicate, reach out, and incorporate the tribal community. Also using the AIM bundle, the postpartum family care plan, because it doesn't just stop there. We know that we have early childhood, it goes on. And we also are working at identifying the locations to be a part of the Thriving Families work that's happening, as well as the Parent-Child Assistance Program that OU has initiated in Tulsa and Oklahoma County. We will be expanding that to the rural communities, and then we will be training statewide, but the evaluation will only be on the 3 communities that we have, as far as being able to expand that service for the 3 years post-delivery. Next slide. These are the proposed sites just based off of some of the information that we initially had gathered based on need and severity of some of the issues. Comanche County, Kake County, and Muskogee, these 3 counties have a lot of the criminal components that we had talked about previously, where they are charging persons that are pregnant with felony neglect charges, basically. Next. So we are looking at, as we spoke with our leadership recently, these are some of the input and priorities for 2023. So we'll create alternatives to incarceration for pregnant postpartum individuals, host a maternal health substance use treatment integration summit is really on our hearts and on our minds. Launch Tough as a Mother campaign. If you're not familiar with that, we can get that link to you so you can see what's happening. It's been initiated in Colorado, and we're working with Colorado to have that here in Oklahoma. Engage, train tribes in all aspects of safer work. launch family care plans statewide, which actually January 1 was the date, at least for our contracted treatment providers. They all are required to now be able to provide that to persons and families. Next slide, please. Creating alternatives to incarceration, recent events. Terry actually, Barbara gave us this publication, a Failing to Protect report, and it was really devastating and worrisome. And so we really want to look at some of the laws that I believe are old laws that have just been there, and they're very archaic and very broad. So we want to increase a request by law enforcement for referrals to pregnant substance users. And then positive meeting with the DA in Comanche County was really good. I can expand upon that go ahead and go to the next slide first. Can you go to the next slide? Yeah. Failure to protect, there's a link there. You can go there and read that or skim through. I'm just going to touch on a few of the main pieces that we are pinpointing and working on. Next slide, please. So as you can see, the women's prison population in Oklahoma has declined since 2016. It's still second in the nation of incarcerated women, which is not great. But that is, I guess the positive is that we're going down, and in that the negative is that we're still one of the top 2 highest in the nation. Next slide, please. 1 in every 6 women in Oklahoma prison is serving a child abuse or neglect sentence, which is one of the main concerns that we have. And top 10 offenses for women in Oklahoma is over here to your right. And as you can see, it's just interesting to me to think that someone is imprisoned for this without getting them the services they need. And helping these families, because a lot of these families do not reunify after they've served their sentence. And when I talked to DOC, I said, what's the average length of a stay for a female? And they said 9 months. So we've created this lifelong traumatic event for these families for a 9-month stint in the prison setting. Next slide, please. Disparate sentences in Oklahoma, despite decades of research, long sentences do not make community safer. We know that. Both child abuse and child neglect in Oklahoma carry up to a life sentence for first-time offenses. Even if no actual harm happens or an adult was not directly involved in the perpetuating that harm, they can be sentenced to spend the rest of their life behind bars, when then the perpetrator may only spend up to 5 years in jail, which makes no sense to me at all. But that's currently how the statutes are written. Next slide, please. Oklahoma's child abuse and neglect law has also been used to punish pregnant women for legal and illegal substance use. As I talked about, Comanche has several, I think 12 cases the last time I talked to them, of persons that were pregnant and had a felony neglect charge impending. Yeah, so they were in jail waiting for that. Since 2019, 24 women have been charged with felony neglect for using marijuana while pregnant, and including women with a valid state medical marijuana license under the care of a physician. The threat of criminal prosecution, Oklahoma has made it harder to gain pregnant patients' trust and to provide treatment. And instead of acting as a deterrent for a drug use, fear of arrest can keep women from seeking prenatal care. And so when we talked about the Tough as a Mother campaign for anti-stigma, it's not just for the community, but also for persons that are pregnant to not fear getting treatment services, that we really want to promote persons getting treatment services, though, that we can avoid the potential of legal and child welfare involvement. Next slide, please. these are the statutes. I won't read all of that to you, but they're available for you to, Barbara has all these slides and can send them out to you. Yeah. So we'd love to host a summit and would love anyone that's on this call that would like to be a part of that, to bring some of the Policy Academy subject matter experts to Oklahoma to pair with local experts, have an action planning day with law enforcement entities, identifying who the potential champions are, and is there readiness and will, and to really make movement on this. Next slide. Like I said, they'll launch the Tough as a Mother anti-stigma campaign. If you'll just type that in, you'll find the one that comes up is from Colorado, and we really wanted to replicate that, but we didn't want to change the name. We love the name of it. So we have an MOU and contract in place with Colorado. They're not even charging us. It's just an agreement. And so we do have a contract with Ghost to get started with the development of the website. We are also working with Storyvine. It is really cool. I mean, you take a video and you can create a video within five minutes, whether it's an agency trying to talk about their services or someone with lived experience sharing their experiences and encouraging others to take action and being in treatment services. And then incorporate this information or the storylines into the summit to be able to get live feed information out to people immediately. Next slide, please. Engaging tribes in all aspects of the SAFER work. And so I think we've talked about it before, but SAFER is this big umbrella that encompasses all 5 points of intervention of a family's life, and the family care plan and teen birth. All of these things are components that fall within that under that umbrella. And so we really want to make sure that we have this available to other persons, and Native Americans are hit hardest by disparities. And so we wanted to make this available to them, and also to ensure that we are being culturally respectful and understanding what is needed. And so inviting them into the conversation to help provide the best feedback and what would work for their community. Active outreach is already underway, as we have several people coming to the Policy Academy and continuing to have those conversations. Our agency has a tribal consultation monthly with many of the tribes. And so we'll be presenting information. And if any of your entities have a tribal liaison, we would love for them to be a part of the work. And then key focus of the 5-year regional partnership grant, which is Compass. Next slide. We talked about the family care plan as just a component of SAFER. And so we do have our Tulsa pilot that's occurring. We are working on the surveys and evaluation of actually the implementation process and what that looks like. So we'll be able to make changes as we move on to rolling out additional pilots. And we will refine those trainings and supports, and we're kind of already in some of the work of that already. And then the full implementation for all sites will be, our goal is to go live summer 2023. And that means really evaluating the entire process and outcomes of the family care plan having for these families. Policy Academy is January 24th through 26th. If you haven't been invited and you want to be invited and you believe it's something that you would be able to provide insight to the work, then please let us know. And then our next No SAFER joint meeting is February 1st, 2023. some of the Omno data.
I think
What
Denise.
is this? This is yours, right?
Yeah, Denise can do this, but thank you.
Yeah.
Teresa, before we move forward, do we have any questions on this Oklahoma Safer and all the work that's Teresa talked about? Well, more to come. As you can see, a lot is going on. And we do want to have a goal of, for those with substance use disorder who are pregnant or become pregnant or in the postpartum period as well. And we want to have a supportive environment rather than a punitive environment. We know that having supports available and ensuring that we provide services and we provide care with dignity and respect is very important to encourage these people to get involved in medication addiction treatment and behavioral health treatment and access other services that they often need, like what Teresa mentioned, legal services, services in finding food or a home. So we're really excited about this work, and it's very complex, lots going on. But let us know if you have any questions, or I have invited a few people to the Policy Academy, and we're happy to invite more. I see some people on here that I need to invite, so I'm going to send a few more of those emails. And I know it's a 3-day event, and we understand you may not be able to attend all of that, but please check out the information and attend as you're able, and let us know if you'd like to become involved more in this work. So thanks so much, Teresa. Appreciate that. And Terry, I see you're off mute, but I want to also thank you for preparing the slides. We got Terry because we participated in this RPG6, and she has been invaluable in this work and supporting us in moving this continuing to drive this train forward. So thank you, Terry.
The one thing I was going to mention, Barbara, was linking back to the earlier presentations by the Maternal Mortality Committee, and that so many of those deaths were pregnancy associated with mental health and substance use. So again, how all of this ties together. And certainly the hope is all of that safer work is going to begin to impact those numbers over time. But putting the two presentations next to each other is like, there's much work to do, but lots of good efforts to get there.
Thank you. Yes, important point to bring up. And Denise, I think you can, if you want to go over this information.
Sure. So one of the things that Teresa mentioned was the AIM patient safety bundle related to opioid use disorder. And for those of you that are familiar with our OMNO initiative, OMNO stands for Oklahoma Mothers and Newborns Affected by Opioids. And this is an initiative that we started back in 2020. March of 2020. And the goal was to assist participating hospitals administer and implement portions of that AIM bundle, in addition to other measures that would improve the care of mothers and newborns affected by opioids. So we have been collecting data from those hospitals since October of 2020. The most recent quarter that we are in the process of analyzing and putting our report out is for Q3 of last year, so July through September. And during that period, we've had 10 hospitals that have reported a total of 116 cases. It's our largest number of cases or records that have been entered so far. I'm not sure if that's a good thing or not. We're hoping that the increase is because hospitals are better identifying the cases of moms and newborns affected by opioids and reporting them rather than an increase in incidence. But if you're interested in seeing the reports, we measure out different things on the maternal side and on the newborn side. I'll drop a link in the chat to our most recent report that was available, which is Q2. And we're in the process of getting that Q3 report report analyzed, and it'll be coming soon. And Teresa also mentioned that we have our bi-monthly Omno and Safer meeting coming up on February 1st. If you're not already on that invitation, but you're interested, please email Barbara O'Brien, and she'd be glad to add you to that invite.
Thank you, Denise. I have a couple of more reminders that I want to share, and then if others have any other business or question, we'll invite you to come off mute. You all have mentioned, we've mentioned before, the Oklahoma Parent-Child Assistance Program. We do have a flyer for enrollment that we've sent out. I'm going to resend again in Tulsa. The staff is in place and they are enrolling families into the Parent-Child Assistant Program for those pregnant and parenting women with at-risk alcohol or drug use during pregnancy. So in the Tulsa area, they are enrolling, and this is the information you can see there. We'll put the link in the chat and the number that you can call to ask questions and or to enroll someone, or ask them to contact so they can contact to become enrolled in this program, I should say. Thank you so much. So we're excited about this work as well. Again, this does support the work we're doing. It's more intense assistance provided for those who have alcohol or drug use during pregnancy. And next slide. Just a reminder, we always want to remind you about the maternal mental health hotline that is available now. And you can see the number there. This is for anyone that is pregnant or postpartum and having any kind of maternal mental health question or issue. Please note, if it is an emergency, we do encourage you to call 988 if you want immediate access. And need someone to provide assistance quickly. But this also is available 24 hours a day, 7 days a week for those who need support or have questions related to maternal mental health. So we hope that you are providing this information out to those who you serve. And also we talked last time about Focus Forward Oklahoma. We have some trainings that are still coming up in March and April for long-acting reversible contraceptive training. This is for providers who actually perform the procedure, for support staff, clinical staff such as RNs, LPNs, or MAs, and or any administrative staff that may be providing practice, be your practice managers or those who are billing and coding or anyone else. So please join us on these dates if you're able to, coming up. And the next slide. Does anyone have any other questions or other business items?
Hi, Barbara. This is Mindy from Take Control Initiative. And
hey, Mindy.
Hi, I'm not sure if this has already been mentioned because I came on a little late, but I'm just putting in the chat that the legislature begins February 3rd, and to make sure people sign up for Matriarch's Fierce Facts to stay in touch about legislation regarding women's health, because it's going to be probably an intense session. So.
Great. Thanks, Mindy, for that reminder. So we will put that, we'll send that out in a what's the latest also for our for those who subscribe, so you'll be aware. But this is a great resource to keep up to date with what's going on in the legislature about surrounding maternal health or women's health in general. And also the Fierce Facts is some very good data and things like that. So thanks, Mindy, for reminding us about that. And I think Denise did provide the link to the maternal mental health hotline so you can give that information to your patients. I think we do have a flyer. We can place that on our website again for you all. And Teresa talked about, Teresa, you want to come off mute and just.
Yeah, so one of our goals or our requests by the federal government is naloxone saturation and fentanyl strips. So if you do not have access to those and you want access, we can get those to you to be able to distribute to persons that you might be serving. And it can be family members. It does not have to be the person that actually has an opioid use disorder. Because of the rise in the use of fentanyl as even a drug of choice and being laced, we are really encouraging people to take more than one kit, and also, making sure those people that are using fentanyl or opioids and other drugs are utilizing the fentanyl strips to test for fentanyl in the drugs that they're potentially using to prevent overdose deaths. So if you need any information on that, you can let me know and I'll get you connected to the right person.
Thank you, Teresa. And I think Barbara Coop will also want to find out more about that too. We can work with our hospitals on getting that information out there. So thanks for mentioning that. I see that we got some links in the chat for you all. And was there anything else that we have? Oh, Tamara Crabtree, thanks for posting this in the chat. The Oklahoma Family Network's Family Professional Partnership Joining Forces Conference is going to be March 31st. We'll also send that out, Tamara, to our on our email list and put it on our calendar. So thanks for putting that in the chat as well. Did I miss anything? I think we got it. So if there are no more questions or comments, we'll go ahead and adjourn. And do want to let you know before that, let you know about our upcoming quarterly meetings this year coming up soon. Gosh, lots of meetings coming up. And reminder to go to our website to register. You will be receiving an email with the link, and you'll be added to a recurring Outlook invite. So there's a way you can make sure you don't miss a meeting. And a reminder of other upcoming events. We have Denise mentioned the OMNO, Oklahoma Safer bi-monthly meeting that will be coming up February 1st. And let me know if you would like the invite to that. The CMQCC is having a webinar February 3rd, Harnessing the Power of Team-Based Care to Improve Maternity Outcomes, Medicine and Midwifery as Partners in Care. So you may want to register for that to learn how we can be partners to ensure that patients have smooth transitions if they need to be transferred between home and hospital, or if there's a physician and a midwife are co-managing a patient, those types of situations. So go to cmqcc.org to register for that webinar coming in on February 3rd. And a reminder that OSU Project Echo has their maternal health echoes every first and third Thursday. And those are from 12 to 1. And you can go to their website to register for those meetings. And I think that that is all. Yes. So thank you all. We appreciate your joining us on this January evening, and we will see you guys hopefully in April at our next meeting, if not before. So thanks everyone for joining and for the discussion.
Yep.